I'd like to welcome you from across Australia to Cancer Council Western Australia's first Cancer Chatters public education series. My name is Melissa Ledger and I'm the Director of Cancer Prevention and Research at Cancer Council Western Australia. I would like to acknowledge the traditional custodians of the land wherever you are today. I'm in Perth, so I'd like to acknowledge the Whadjuk people of the Noongar Nation. I would also like to pay respect to elders past, present and emerging, and offer acknowledgement and respect to Aboriginal and Torres Strait Islander people who are present today. Today's presentation will run for about 45 minutes and we'll have questions for those people who've logged in to join us. I'll ask that you please use the question and answer button, and as a question pops into your mind throughout the talk, please just type that through the question and answer function, not the chat function. And at the end of the presentation, Professor Gottardo will get to those questions. We've been holding public education sessions now for 25 years and have always attracted high calibre speakers, and today is no exception. And I'd like to introduce Professor Nick Gottardo to you now. Nick is a clinical scientist based in Western Australia. He is a consultant paediatric oncologist and neuro-oncologist and head of Department of Paediatric and Adolescent Oncology and Haematology at Perth's Children's Hospital. He is also the co-head of the Brain Tumour Research Program at the Telethon Kids Institute and the Stan Perrin Chair for Paediatric Oncology and Haematology. It's with great pleasure that I introduce Professor Nick Gottardo for today's first Cancer Chatters presentation.
Good afternoon, everyone, and thank you, Melissa, for the kind introduction. I've never given a talk quite like this before, so let's see how we go. I'm used to giving presentations to a live audience. So, as Melissa said, I work as a clinician, so I look after children with cancer, and the area of my sort of area of expertise and specialization is actually childhood brain cancer, though here at Perth Children's I look after all children with cancer. I also undertook training to learn how to do research to see if we can change the current paradigm on how we treat childhood cancer. And in this talk, I'm going to take you through a journey which encompasses the past, the present, and hopefully the future of childhood cancer, brain cancer care, and how we might change the current situation. And I will speak to that more shortly. So let's begin. Okay, so if we took a pie of childhood cancer in general, we can see from this pie here that about a third of children with childhood cancer will have leukemia, of which there are a number of different types, but usually and the most commonly it's acute lymphoblastic leukemia. And then the second biggest portion of this pie you can see is what's called central nervous system, which actually essentially stands for brain tumors, which is about 20%. So it is the second biggest group of tumors that we as pediatric oncologists take care of. And if you put it in simple terms, it's 1 in 5 childhood cancers will be brain tumors. And of course, not all brain cancers are the same. There are over 100 different types. So individually, they're all very rare, but collectively, as I've just mentioned, they constitute 20% of childhood cancer. I will just use a few examples in my talk, particularly around medulloblastoma, which is the most common malignant brain cancer. It comes under the green portion of the pie that you can see here, which is comes under embryonal tumors. But a lot of the principles apply in general, but I don't have the time, obviously, to go through individual different types of brain tumors. Now, the one thing that has been a remarkable success story in modern medicine is how we have cured the vast majority now of children with acute lymphoblastic leukemia. If we were sitting here and having this talk in the 1950s and 60s, the vast majority of these children with acute lymphoblastic leukemia would have died of their disease. If we now project it to what the situation is like today, some of the more common types of acute lymphoblastic leukemia, of which there are multiple different versions and molecular types of the disease, but the most common one, which is known as the standard risk, that's got a cure rate now of 95%. Now, that's not to belittle the treatment that these poor children have to go through to get that cure. It's a very intensive regimen of a cocktail of different, very powerful drugs with lots of side effects. But the end result is a cure for most. And that really is what we would like to emulate for brain cancer. Now, these graphs here these are Australia-wide statistics, and they simply highlight the point that whilst we've had progress in the cure rates for lots of different types of childhood cancer, and in particular leukemia, as I've highlighted, the curves, the survival curves, have just not shifted for central nervous system tumors, of which the vast majority are brain tumors. The reason it's called central nervous system tumors is because it also encompasses children that have spinal cord tumors, which are actually quite rare, but that's the terminology that's used. Here I'm showing you a pie of some of the more common types of brain cancers that occur in childhood. And you can see here we've got ependymoma, high-grade glioma, medulloblastoma, and brainstem glioma. And what is notable instantly is this wide variance in survival. So medulloblastoma, which I've already said is the most common malignant brain cancer of childhood, actually is also a success story in that the majority of children are now cured of this disease. It's up to, around 60 to 80% survival, depending on what risk factors the child presents with. And we'll talk about some of these later on. But the treatment that we have to use to cure them is pretty harsh and involves radiation, chemotherapy, as well as surgery right at the beginning. And it does leave the children with multiple and permanent side effects, which do impact on their quality of life. If we look at the third most common tumor that we look at, which is ependymoma, that survival is a bit less. It's about 50 to 60%. We haven't made enormous strides in that disease over the last 20 years, and the same really could be said for medulloblastoma. The treatments that we're currently using are very similar to what would have been used about 20 years ago. On the other side, we see these other two types of tumors. One is known as a high-grade glioma, the other one known as a brainstem glioma. They've currently gone through some changes in their nomenclature. Most people would know the brainstem glioma as a DIPG, or a diffuse intrinsic pontine glioma. You can see, I'm not sure if you can see my arrow, but if we look at the lower MRI scan, there's like a bulb in the brainstem of the child that I'm just circling with my arrow. That disease, I've written up to 5%, but that's actually being optimistic. I personally have never had a patient survive this disease. I did meet a little girl in the United States where I was training who had survived it, but you're talking miracle type situations where these kids survive. Generally, they will succumb to this disease by 2 years. About half of the children will die by 1 year, and the remainder will die by 2 years. It generally inflicts younger children, average age of about 5 or 6 years old. It's a dreadful disease. The only thing we can do is slow it down by a bit with radiotherapy. And high-grade glioma doesn't fare much better. There are some survivors, usually what is termed a grade 3. Grade 4 is unforgiving, and there are very few survivors. So you can see that even though we call medulloblastoma a success, there is a price to pay for that cure, and I'm going to talk about that in a coming slide. So what we really want to do is emulate this success in leukemia, and I'm going to show you how we're trying to do that as a community. It's an international effort and we here in Perth are one piece of a very large jigsaw puzzle of a team of very committed individuals, both scientists, clinicians, nurses, and the broader teams that are really working hard to see if we can change the current paradigm. So one of the most notable things that we've learned over the last decade is that medulloblastoma, whilst it's one word to describe a disease, is actually composed of four very different diseases when you drill down to the molecular level of this disease. And this is very important because what we've learned is that the same treatment given to one subtype of this disease will not be as effective in another subtype, or vice versa. So for example, this what's termed WNT or WNT, standard treatment for this disease has got a very high chance of curing a child, 90 to 100%. In contrast, group 3 disease, especially if it has a gene called c-MYC present, carries with it an abysmal prognosis with little chance of survival for those children compared to the WNT group. So it is important you understand your enemy, and by understanding the molecular underpinnings of this disease is helping us to try and stratify the treatment and have types of treatment that are specific to the different molecular subgroups. And this graph kind of demonstrates the different types of survival according to which different molecular subgroups the children have. And it's this type of information and technology that we're using which is helping us work to find better treatments and hopefully less damaging treatments for these precious children of ours. So the current treatment I've already mentioned to you guys involves neurosurgery at the beginning. This begins the journey for the treatment journey for the child. It plays a very important role in the treatment, both from the removal of the tumor, often in its entirety, where possible, which starts the treatment journey, as well as provides the tissue for the diagnosis. Then most children, but not all, will undergo radiotherapy. And the reason I say not all is if a child is very young, and the definition of what is very young does vary from country to country, but in general, less than 3 or 4 years of age, we do try and avoid radiation to the whole brain and spine. We may use radiation just to a focal area, just to one part of the brain, but not the whole brain and spine because it's so damaging. And then all the children will get chemotherapy, and this generally takes about 12 months worth of treatment, and it is very harsh, and these kids get very sick, but many will recover. But those that are able to recover and their tumors don't come back, then they're left with a number of different side effects, which unfortunately tend to be permanent and tend to often worsen over time. And this is where we have to juggle the price of cure, and we have to make sure that our remedies are not worse than the disease itself. And this is not something that I've came up with, but actually a much smarter person than me many centuries ago. One side effect that I'm noting here is intelligence. This is the IQ score. And the take-home message here is the higher the dose of radiation and the younger the child, the greater the damage to the child's intelligence. Now, it's not just the child's intelligence, but it affects their working memory, it affects their attention span, it affects their hormones, it can affect their hearing, it can affect their vision. And so it has multiple different areas that it can damage. Hence why, even though I say that medulloblastoma is a tumor that we're successful with, it comes at a real price. In contrast, most children that are cured with leukemia, whilst they have a rough time during the treatment and they are left with some potential long-term effects, by and large, they can lead long and healthy, fairly normal lives. whereas children that have been treated for brain tumors often cannot. What I want to demonstrate here, and I'm not going to labor, is that what we've done for medulloblastoma, at saying there are different molecular subtypes of the disease, the same we have done for many other different types of brain cancer here. What we've noticed is a common theme emerged, that tumors that were once regarded as single entities have been shown to include multiple subgroups. So we're not treating a single disease under the banner of, say, ependymoma or medulloblastoma. And this is critically important because, again, they respond differently to the same treatment. Therefore, we need to adapt the treatments to be specific for the disease we are treating. And this is where advanced molecular diagnostics plays a critical role, because under the microscope of a pathologist, it is very difficult for them to be able to call a tumor such as medulloblastoma according to its different molecular features. There are some tests that they can do that can help with that, but they're quite crude and they're not often very accurate. Hence why we partnered up with the mighty Germans at the Heidelberg that introduced a system known as DNA methylation profiling. And so we worked very closely with the Germans and have been doing so now for a good 5+ years, where samples of Australian children's brain tumors and spinal cord tumors have been going to Germany to have advanced molecular testing to really help with this diagnosis, to know which molecular subtype we're working with. They also can help in working out what type of tumor, when sometimes the pathologist just cannot tell under the microscope. Not because the pathologists aren't good at their job, but in fact, in contrast, the pathologists are very good, but sometimes the cells themselves are so immature and so primitive that it is very hard for the human eye to be able to discern the cell from one type or another, and so it can make diagnosis very challenging. And the beauty of this technological system, and what we did when we partnered with the Germans, is we couldn't always forever keep sending samples to Germany. Is we used the opportunity to establish the same platform here in Australia, so that we had an Australia and New Zealand wide service to be able to provide for all our children. And that we put it in Melbourne at the Monash Health at the Hudson Institute, because that was kind of central for Australasia, if you like. And this is just to give you a sort of snapshot, the graph basically showing hundreds of different tumors and how they are clustered into their separate different categories, as is depicted by the different colors. It's basically a chip which reads 850,000 data points, and what this chip basically issues you is a fingerprint of the tumor, which is unique to that tumor. And there's a database with thousands and thousands of these now that been built by the Germans, which includes a large number of Australian and New Zealand samples, where it learns. The more you put in, the more it learns. And we have identified new tumor types which were previously unknown of, and we have refined the diagnosis for other types, so that we are better able to provide a diagnosis that then helps myself and other clinicians to actually treat the patient's specific disease. This is no longer a pipe dream for the future. This is here and now, and that we are hoping that this technology will be integrated into a diagnostic report, and that's what we're aiming to do. So this is like the future is here. Now, what I want to move now is the future is here in terms of treatment too. And this is a fascinating story that I use as an example of understanding your enemy, the disease, and then how that helps you then target the disease. And I'm going to use this example of what's known as the sonic hedgehog subtype of medulloblastoma, known as SHH, and it was depicted in red in the previous slides that I showed in the 4 different subgroups of medulloblastoma. And it's a fascinating story how this came about, but basically what the way the story evolved was a farmer made an observation that certain lambs that were being born on his paddocks, this is in the United States, were being born with one eye. So they had what's known as cyclopia. And there's a picture there of what these lambs looked like. And he made the observation that it was the lambs whose mothers had eaten the corn lily, which has got its fancy Latin name as Veratrum californicum, California false hellebore. So this is on the west coast of the United States. And so he shared this information with scientists because basically what was happening that is the ewes, when they were eating this particular plant, what was happening, there was a chemical in there known as cyclopamine, which was blocking a pathway in the lamb's development when the lamb was an embryo and a fetus, which was critical for the development of certain parts of your brain, but also of your eyes. And if you took it, you basically ended up with one eye instead of two. Now, what's this got to do with brain tumors? Well, because, and this is back in the 1960s. Later on, what happened was other scientists working in the field realized that the sonic hedgehog pathway was critical for the development of the cerebellum. And in fact, there were children that had medulloblastoma who had genetic abnormalities in this sonic hedgehog pathway, which resulted in the child developing medulloblastoma. So in other words, an abnormality in this very important developmental pathway could result in medulloblastoma. And because this farmer made this observation back in the 60s, they then developed a drug which they took the active compound from the plant and treated some mice that they'd genetically engineered to develop this disease, and found that these mice, it blocked tumor growth, and the tumors actually stopped growing, and not only stopped growing, they actually disappeared. And this was a seminal observation in fundamentally demonstrating that you could block the tumor growth and actually make the tumor go away with a single drug targeting what the tumor needed to survive, which was abnormal amounts of this sonic hedgehog pathway. And this is an example now back from 2009 of a patient, and this is actually an adult patient, because adult patients can get medulloblastoma, but if they do, they usually get the sonic hedgehog variant. And this patient had been treated, you see in figure A, where you see black is the brain cancer that is spread throughout this poor young man's body. And this patient had undergone treatment with multiple different chemos and radiations, etc., and was actually not far from passing away from his disease. And the doctors treated him with the medical drug version of cyclopamine, and there was a miraculous disappearance of the disease. The problem was the disappearance wasn't long lasting. It lasted 2 to 3 months, and then the disease returned because the tumor developed mutations to it. But what it highlighted was a proof of principle that a single drug could target these tumors very specifically with minimal side effects to the patient and very effectively. And now what we're trying to do is apply it to children with brain tumors. And you can see here, this is a colleague of mine in St. Jude, Giles Robinson, who published this about 5 years ago from a little boy or girl, I don't actually know the gender of the child, who you can see the arrow shows a medulloblastoma that has come back, and then 2 months later you can see the medulloblastoma has disappeared, and then after 4 months though, unfortunately, you can see a little nubbing of tissue coming back, and then it regrows. So again, showing very effective but only transient benefit. So how do you turn this transient benefit into a long-lasting benefit? Well, we believe that maybe the key is by combining it with our current treatments. And so we currently have a clinical trial here and now open, and it's available here in Perth as it is in other parts of Australia, called SJMB12. We're working with the gentleman in the corner, which happens to be my mentor and my trainer back at St. Jude, Dr. Amar Gajar, probably the best medulloblastoma doctor in the world. And he has devised a treatment that involves our conventional treatments, but it also combines in this novel drug that targets patients with sonic hedgehog medulloblastoma with the specific targeted drug, in the hope that we may reach more like 90 to 100% cures for those children. So this is the future, again, is here and now with us with these fancy targeted agents, but we are combining them with current agents to see if we can make the current treatments more effective. So now moving into, well, how do we translate these sort of new findings, this new technology, all this understanding of the tumors into new cures and more cures for children? And what we did is we partnered up, again, I've shown some of our partners here at the bottom from Germany, from St. Jude's, and from San Diego at the Sanford Burnham. We actually got together back in 2012 and had a workshop with 50 of the best from around the world to come up with an action plan of how we might defeat medulloblastoma as a global community. And we in Perth took one component of the jigsaw on how we might do this, and we developed a system to try and take clinical discoveries in the laboratory into the clinic in the form of clinical trials. And as guiding principles were actually quite basics and based on observations that we as doctors treating children with cancer make every single day. And the first observation is that to cure medulloblastoma, you only get one chance. So you cannot wait for the child to relapse to be able to try and cure them of their disease. Whatever you introduce to cure them, you're going to have to do it and give them that treatment at the beginning when they're first diagnosed. The second observation is that we would introduce something new on the backbone of our current treatments. We can't just suddenly we're curing somewhere between 60 to 80% of children with medulloblastoma. So our current treatments are working. They're not working for all, and they leave a lot of side effects. But if we're going to move the paradigm, we're going to have to work with what we've currently got and add to it. And hopefully in time, we will be able to reduce and remove some of the more toxic elements of treatment. And then the third and obvious observation was that it's unlikely that one single drug is suddenly going to cure all children with brain cancer. Even though I showed you that picture, which was remarkable for one drug, you could see that it did not last for very long. So as exciting as that was, it's just not enough and it's not good enough. And we want to cure all children, not just buy them a few extra months of life. And so based on that principles, we developed a program around developing model systems of brain cancer that centered around modeling the disease in laboratory models. Here's our brain surgeon, Dr. Sharon, collecting a sample now with the right ethical approval and consent. We take a bit of that sample and it gets distributed to various different parts of the program. Firstly, it goes to diagnostics, and part of diagnostics, it gets sent to Germany, it gets sent to America, to St. Jude, where they do the current molecular stratification. Some of it gets stored for future analysis. Some of it gets implanted into our clinic of mice, which is basically we try and implant the tumor from where the tumor originates in the child, and then we also try and grow the cells in a culture system. And in this way, we're kind of creating an avatar system where the child's tumor is in the same position in the brain of the mouse so that we can then do clinical trials, but on the mice to test new upcoming treatments. And using that approach, we utilized this very sophisticated robot here, which was actually in Sydney at the Children's Cancer Institute, where it can test thousands upon thousands of different drugs and compounds to see which ones might kill a brain cancer. In this instance, we tested medulloblastoma, but you can apply this principle to any of the brain cancers. And out of 3,000, just over 3,000 drugs tested, we stumbled across about 50, not stumbled, but we found about 50 that were effective. So that goes to show that the vast majority didn't work. And some were very effective. And we took a particular example of what looked like the most effective, and we did extensive testing in that. And that's what I'm going to describe to you for the next 5 or so minutes. These are known as cell cycle checkpoint kinase inhibitors. And their modus of operandis is they prevent a cell's ability to repair damage to DNA. And the way chemotherapy and radiation works is by damaging DNA. And so if a cancer cell is hit by chemo, it can essentially go into a state of, if you like, hibernation. It can repair that damage and then come back at some time later. And that unfortunately manifests as a relapse of the disease. What these drugs were designed to do is to prevent the cell from being able to repair that damage, and therefore should make your chemotherapy and radiotherapy more effective, hopefully resulting in more cures. And so we set about extensive testing of a particular group of these drugs that exactly did that. And one of the first things we wanted to do was to make sure that these drugs actually get into the brain, because a lot of drugs are designed by drug companies never to enter the brain. And so if you can't get into the brain, you're not going to cure brain cancer. And so this very smart guy called Clinton Stewart has devoted the last 2 decades in developing a system where you can measure accurately how much of the drug gets into the brain, and particularly into the brain tumor. It's very technical and very sophisticated, and I can't pretend to understand exactly how it comes out with the mathematical equations that tell me how much drug gets into the brain tumor. But it is critical information, because you're never going to defeat a disease with a drug if that drug does not get to the disease. So this is very fundamental. It's laborious, painstaking work, but it does give you a very accurate idea of how much drug gets into the tumor. We then set about, and I'm not going to take you through the whole of this slide, but essentially creating a clinical trial for the mice harboring these tumors that came from the kids. And we did this here in Perth, and our colleagues did it at St. Jude and at San Diego, so that we had independence and robustness to try and replicate results, so that we were only going to take to the clinic something that we truly believed should work, by having done as much testing on it as is possible. And so we essentially tried to treat the mice with the tumors from the children in as close a way as we would if we were going to treat children. And what this figure at the bottom shows here, with the different, it's a graph. It shows you the purple, which is the mice. It's a graph depicting survival, how long the mice survive. And the curve which is purple is a combination of chemotherapy with the drug, the experimental drug, compared to blue, which is just the chemotherapy by itself. Red is just the experimental drug by itself, which you see does extend survival, but minimally. And the gray line represents what we call the control, which is where you're treating the animals only with the carrier substances, but not with active drug. And the figure above it is kind of depicting it in pictures using a bioluminescence, which is a way, it's a bit like MRI, except I call it a poor man's MRI, is you label the cancer cells with a bioluminescence emitter, so that when light hits it, the more tumor is present, the more light you get. And what you see here is that in the control, you can see that after 6 weeks, the tumors have grown markedly. With the chemo by itself, you can see it slows the tumor growth. The drug by itself slows tumor growth, but not as good as chemo. But when you combine the two together, you can see there is no tumor when you look at gemcitabine and the LY2606368 compound. And we did this using a number of different compounds from different companies. Again, we didn't care which company it came from, as long as we just wanted to find the best one. And then this, I'm not going to clearly take you through this, but this is to show you how extensive testing we've done to try and convince ourselves that we were going to take something into a clinical trial that had the biggest chance of working. There's no guarantee ever in a clinical trial that things will work, but we wanted to get as much data and as much information as possible to try and replicate the clinical trial in our mini clinic of mice. And you can see that by and large, we're doubling or tripling survival of the mice. But importantly, we're not curing the mice, because we're not able to treat them like we could treat a child, because we can't give them the same level of supportive care that we do children with cancer, like blood transfusions, etc. We just can't do that in mice. So the combination of that data culminated in a new clinical trial, and it was a joint effort between ourselves, our friends at St. Jude, and our friends in Germany at Heidelberg, to now bring that drug into the clinic, having done this extensive testing over a multitude of years. It took about 7 years from finding the drug to bringing it to clinical trial. And this clinical trial is called St. Jude Eliot. Why is it called St. Jude Eliot? Well, we named the trial in honor of the little boy that actually inspired much of this work, because it was his mum and dad. I was looking after Elliot many years ago when he was a little boy, and he had medulloblastoma, and his parents began a major fundraising campaign to try and find a cure for this dreadful disease that took their little boy. And they actually were the ones who sponsored and had the idea around bringing that workshop style group together of the 50 best of the best from around the world back in 2012. And St. Jude Eliot is the culmination of those 7 years plus of work, and hence we wanted to honor Eliot's legacy, and we named the trial after Eliot. And the trial is now here in Perth, and it's also in the United States. It's also open in Melbourne, Sydney, and in Queensland, and is recruiting children. Now, it's a phase 1 trial, because firstly we have to test the safety of combining the chemotherapy with the new drug in children, because it's one thing doing it in mice, it's obviously a very different thing doing it in children. So it's a phase 1, so we're just trying to find what is the optimal dose, and the children we're treating at this stage, their diseases come back. So they're not children at the beginning of their journey, they're children who have failed conventional treatment, because that is the only population of patients that you're generally permitted to test phase 1, do phase 1 clinical trials. Now, what next? Well, of course, chemo is only one part of our armamentarium. The other part of our armamentarium is radiation. In fact, radiation is the best treatment for brain cancer, but unfortunately it's also the most damaging. So it's one that we oncologists would love to do away with, but at the moment we can't get rid of it because it's too good. And what we want to try and do is phase it out. And so one of our ideas is, if we can combine it with drugs that make irradiation more effective, then potentially that would allow you to turn down the dosage, because there's a very clear relationship between dose and the damage it causes. The lower the dose, the less the damage. And this basically summarizes all my slides into one slide about the program that we have developed here, again, as one part of a much, much bigger jigsaw. We are one component. This is not a disease that we can defeat as individuals, but it's a disease that we can defeat as working as a collective. And that is, you've seen how the Germans, out of their generosity, opened up their platform to Australia and New Zealand. All we have to do is pay the shipping costs, and they do all the testing for us. And they've allowed us to essentially copy their technology and apply it in Australia. And they're more than happy for us to do that. And because that is the best way for us all to work together, is to make other nations be able to do the advanced diagnostics rather than everybody rely on sending the samples to Germany. And so this really summarizes the testing we do. Starts with the patient, the samples gets divided, it gets sent all around the world for this advanced diagnostics that helps treat children on clinical trials. We also use the samples to create the avatars to find the next generation of drugs and treatments that will be applied in the future in the form of clinical trials. And I won't go into this, but St. Jude Elia is an example of a trial that has come out of research that was done in a bench here in Perth. You need state-of-the-art equipment, which we now have here in Perth. In fact, this was the only machine in the Southern Hemisphere. For a while, I think there's one now in the east coast of Australia. But we were ahead of the curve in trying to get the best equipment so that we could make the earlier innovations and advancements. There are a number of other drugs that came out of the high throughput robotic testing, which we're now in the process of testing, and those are highlighted with the arrows there. So I didn't want St. Jude Eliot to be the end. I wanted to be the beginning of many new drugs that will come through. And inevitably, some of these will fail, because what works in our model systems may not work in children, but it is a system that we hope is robust and able to convince us that it's rational to take certain drugs that have been extensively tested, but not just by us, but by others, to do it independently, so there's no bias introduced. And then we also collaborate with other Australians. This is Professor Brandon Wainwright over in Queensland. He's testing, and we're helping him test a drug called palbociclib, which equally was shown to be very effective in some models of medulloblastoma. You can see the survival here, the red versus the blue. And now also the new kid on the block is immunotherapy. And it's been very successful, CAR T cells in leukemia. In fact, we're sending children now to Melbourne and Sydney with leukemia when they've run out of conventional options. And we're now wanting to see, well, can CAR T cells work in brain cancer? So we're working with a very esteemed team over at the Walter and Eliza Institute in trying to develop CAR T cells also for brain cancer, in the hope that we may be able to harness the immune system to destroy the cancer cells in the brain more efficiently, and maybe do away with the traditional treatments we currently use. So this is now one of my end slides. It really shows what a team effort this is. It's a global effort where, honestly, people are truly working together. I mean, I can shoot an email to someone in Germany or to Memphis if I need a second opinion, and often I'll have an answer within minutes, certainly by the next morning. It is a true global community, all working together with the common purpose of trying to defeat these dreadful diseases that are a blight for some of our children. This is the team here in Perth that did all of that work. I did not do any of that work myself. Unfortunately, I don't think they'd let me in the lab anymore. I probably would make a mess of any of their experiments. The lab is under the great leadership of a dear colleague of mine, Raylene Endersbury, here in the middle. She also was trained at St. Jude, so we came with a similar ethos and a similar background, and she runs the experimental arm of the brain tumor program. I run the clinical arm, and the team behind her and to the side is a team of very young and smart and very dedicated people that have really want to change the current paradigm. And of course, importantly, there's a whole team of international collaborators, of which are listed here. importantly also, none of this work happens without funding, and we get funding from a number of different sources, including government and philanthropy, and not least of which is the Cancer Council WA that supported me for many years in my journey. But most importantly, it's the families and the children that entrust us with their precious samples really to undertake.
Nick, we've got a couple that have come through, and I might just read out the ones I've got in front of me as well, if that's all right.
Of course, fire away.
So the first one was just around if Australia had similar survival rates for medulloblastoma compared to similar countries of, similar income is the question. So are we about the same in terms of survival for other countries?
Yes. We in terms of survival, Australia compared to other nations, we're roughly the same. I mean, if you drill it down to, when you see those type of statistics where they're not down to individual groups of diseases, actually Australia might be 1 or 2% ahead, but in reality, it's about the same. So because the treatment you would get here is actually, because we use these international clinical trials, is the same as you would get somewhere else. So if you happen to be in San Diego, you would get St. Jude, or you would be offered as a family St. Jude 12, SJMB 12, just as you are here in Perth. So we try and work as an international collaborative community, because trying to do it individually by yourself actually is a terrible model, because we have maybe 4 to 5 kids a year that get medulloblastoma here. How could I ever put together a meaningful clinical trial that would ever give meaningful results with 5 kids a year? So that's why we work as a global community. But statistically, our results are the same as any of the other developed nations.
Thanks, Nick. And I should have, before I launched straight into the questions, I should have said thank you so much before I even got into the questions.
My pleasure.
Great presentation.
Yeah, no worries.
Really very interesting. And I'll encourage anyone who's still with us just to please pop your questions in the Q&A section of the fields there that you can see, and we'll get to those as well. We've got a few coming in, and the other one that I've got also was just around what research, if any, has happened around what increases risk of children developing this cancer as well. So is there some early prevention message that might come about if we know what increases risk?
So, this is the big difference between adult and childhood cancer. There is no prevention for childhood cancer that we know of, okay? By and large, we do not know the causes. We know that some of the children will get a cancer because they have an underlying inherited gene, but that is only for some children. The vast majority, it's a spontaneous event that occurs in a cell that's gone rogue during the child's development. Now, the hedgehog type is the one type that does seem to be associated with some familial inheritance, but by and large, we can't prevent it. We can't screen for it. That's why all our efforts are going into better treatments. It's not like breast cancer or cervical cancer where you could do screening or colon, because you can detect it early. There is no such thing that works, because we can't predict who's going to get it versus another, unless we happen to know of a particular gene that is inherited, which is by far the minority of the cases. So it's only a handful where we might do screening because a child carries something called Li-Fraumeni, for example, which is a gene that is inherited that predisposes you to cancers as a child or a young adult, or adolescent or a young adult. The vast majority of kids, it is spontaneous, and it's occurring as a cell that's gone rogue. I've got a few. Have you got any more questions? Because I've got a few here.
There's just one on the Q&A if you want to have a look, Nick. I'm not sure if you can see it. It's quite a clinical question about a particular case. So I'm not sure if you can see that and how comfortable
you are.
Yes,
I can. Can I read?
I'll leave that with you.
Yeah. So I'll read it out, and that way I can process it as I'm reading it. For an 8-year-old with an optic nerve glioma that has not grown since it was found under MRI 5 years ago, is the advice to keep doing annual MRI to ensure it is stable and not growing. It is an area almost impossible to operate on, so it has not been removed. It is simply being monitored. She also has morning glory in this eye, so her sight is not good in this eye. We are in Perth and under the care of Dr. Lam, who is a fantastic ophthalmologist. Thank you for everything you are doing. Also, it says she has had genetic testing to rule out NF1. The current recommendation from Dr. Lam is to wait and see and monitor the optic glioma to ensure it is not growing. Apparently, by the time she's 10 years old, we should have some comfort that it may not grow as she gets older. Nick, we are in Perth and I have ticked the anonymous box. However, if you have any guidance for us, it would be appreciated. We are relying on Dr. Lam, who is not a brain cancer specialist, to guide us. However, he talks to us all the time. I can reassure you there. I'm very happy to contact you and give you some reassurance about what Dr. Lam is doing is absolutely spot on. So just for those in the audience, optic gliomas are they're called they're a type of tumor that is sometimes called benign. I don't like the word benign because they're far from benign. Benign suggests they can cause no harm. The better term is low grade versus high grade. So for example, a medulloblastoma would be a high grade tumor. They grow very fast, very rapidly, and kill very quickly if they're not treated. Low grade gliomas generally grow very slowly, or sometimes not at all. And therefore, they often don't kill, but they often can cause severe damage. This particular type sits in the parts of the brain that controls vision and actually can occur inside the nerves of the eye, which are obviously essential for vision. Now, we know these tumors can grumble, and we only treat them if they cause problems. So if we identify them, then what is recommended is that you do ongoing monitoring of both the vision and MRIs. Now, no one really knows how long you should keep going with the MRIs if they're stable. It's probably, 5 or so years is probably enough, particularly if you're doing eye monitoring. But no one truly knows, because sometimes these tumors can just have a little growth spurt, and that's when they can affect vision. So of the two, the most important factor is Dr. Lam doing the regular monitoring, because that will determine if we treat the tumor or not, because it's the growth of the tumor affecting the vision, which is what we treat. And our treatments are not, sadly, they're not curative. So we can't get rid of these tumors because, as you have rightly pointed out, you cannot remove them by surgery because they sit in the middle of the brain. And if you remove them, you cause more damage than actually the tumor could ever cause. And so we rely on basically drugs and chemotherapy drugs to stop the growth of these tumors. But we only treat if they're causing harm. There are many kids walking around with these, either don't even know they've got them, or if they've got them, they're not doing anything. So surveillance is the key to this, and it's usually a combination of scans and eye appointments with checking the vision. And of the two, I feel personally it's the eye appointments and the vision testing which is the most important, because just because the lump is there does not mean that I will treat it. It's if the lump is there and growing and causing harm or potential harm to the vision. I hope that answers your question, but I do have your details there, and I will endeavor to give you a call and hopefully try and provide you a bit more reassurance. But what Dr. Lam doing is absolutely spot on. There's no issues there. I don't think I can see no more questions, actually. Have you got any more, Melissa?
No, Nick, I don't have any more, and we're just about out of time, so I think we might just wrap it up. Oh, actually, one more might have just come in at the very end. Oh, it was a thanks so much. That's lovely. I think we might call it a day for our very first ever Cancer Chatters, and just thank you so much, Professor Nick Gottardo. I really do appreciate you doing this for us. It's such a strange time, isn't it? And talking to an empty room is certainly something that we'll have to get used to, but we really appreciate the time that you've taken to walk us through what is a really complex disease and really does have an enormous impact on those people affected. And I think really just highlighting today the importance of research that can help bring hope to diseases like this. And I guess it's a nice segue for me in that Daffodil Day is August, and Daffodil Day is one of our largest fundraisers and goes towards funding our cancer research funding program. And without that kind of cancer research funding in an ongoing way, this kind of work in Perth and Western Australia, nationally and internationally, doesn't happen. So if anyone's still listening and would like to support Daffodil Day, there's plenty you can do if you'd like to pop onto our website. But Nick, thank you so much. We really appreciate your time today and just spending a bit of time highlighting medulloblastima. So,
it's my pleasure. I'll just take the details down of the lady who asked me the question so I can contact her, because if it disappears, then I don't know how to get it back.
Let's work with her. Yeah, no problem. And thank you so much to everyone who's still with us and giving those wonderful words of encouragement to Nick. I'm sure he's very grateful for that as well. So thank you so much for letting us know. Thank you.
It's a pleasure. Thank you so much. Take care now.